introduction, I invite Dr. Yash Patel to deliver his lecture. Over to Dr. Yash Patel.
Good morning, good evening, and good afternoon to all of ourselves. And it is indeed pleasure to be part of this hybrid RSSDI Gujarat chapter meeting. And it is indeed pleasure to be there virtually and represent the hybrid part of another part of virtual platform. I would really appreciate what our seniors or the chapter members have provided. Dr. Pratap Jethwani, Dr. Shailesh Trivedi, Dr. Bansi Sabu, thank you for inviting and making this conference as live as possible. And Dr. Udman sir to congratulate for further upbringings of this chapter. All faculties who are at venue, it is pleasure to be there with you. And all faculties and dignitaries, delegates who are virtually attending, it is indeed pleasure to have this talk. Prevention of amputation in diabetes management, is it real, or we are still in dream to achieve that reality? So yes, RSSDI Gujarat chapter, all members, we have legacy, and that legacy what our this body has provided till time is the level of energy, level of innovations, and the dedication to the cause of diabetes care. And to make it to further level, it is indeed pleasure to be part of this team and represent the Gujarat side of diabetes care in RSSDI. So to my talk, what I had been asked for is prevention of amputation in diabetes management, and how we can achieve this from dream to reality is, and what is the background is why we should look for, what is the present scenario, and how we can cope up to that dream. To that note, just provide the background for the same. And in the same, we know the food has been always forgotten child of medicine, and though it is forgotten, but it is glamour part of our body. And still, for healthcare providers, it is unglamorous as it can be, and hardly given any attention from our side. For patients' point of view, it is yes, most feared complications, and from doctor's point of view, it is most devastating to look for. We know what is magnitude. 25% of diabetic individuals look after to the foot ulcers in their lifetime, and this diabetic foot is the commonest cause of hospitalization in these individuals. Diabetic foot requires longest hospital stay, and it is one of the major cause for 40 times more likely to lose leg in those individuals in diabetics. Even 85% of amputations, these are proceeded by the tribal foot ulcers, and 75 of those leg amputations happens in people with diabetes. 1 million people lose a leg every year. So this is what the present reality is. Though every 30 seconds, IDF presents the data, every 30 seconds, a leg is lost somewhere in the world, and that causes diabetes. So where is the dream of achieving the prevention of amputation, and where is the reality we are facing? If we are able to reduce this number from 30 seconds to 1 minute, we are almost reducing the burden by 50%. Why do diabetic patients get food problem? And if we see, 80% of ulcers of diabetic subjects are from external trauma, and 4 to 10% of those ulcers are due to preventable foot ulcers. If we see the responsible factors also, neuropathy, major cause, peripheral vascular disease, yes, we look after, surgical people more look after, foot deformities, careless, ill-fitting shoes, poor visions, elderly people, and nephropathy somewhere, and the glycemic control, where we all focus on. But what are the etiological distribution of these incidents? 45 to 60% of neuropathy caused these foot ulcers. So foot ulcers represented by neuropathy etiological causes are 45 to 60%. If we see the neuroischemic, 25 to 45%, and 10% is pure ischemic. If we see the 2017 pre-data, where we have not exceeded the milestones of getting to the timely manner of those targets, but if we see this to the further IDF, we have reached the number much more. Previously, it was 72 million suspected to be progressed, and now it is 82 million from Indian populations. This is a target which we are achieving 2045. And though what we are looking after is the incidence is rising, the prevalence is as high as possible, and what is the foot care of Indian standard had been represented in our mythological structures. and where we are at present is a real question. And as we know, up to 85% of these amputations are preventable when they are managed comprehensively. Though that still we achieve this in our OPDs, and that is still not achieved with our milestones. Even to add on the further aspect, the prevalence we know at any state it is 12 to 15 percentage, and this all population by 2045 we are susceptible to the major cause, I would say the third cause for overall healthcare expenditures of any diabetic individuals. Almost $7 million are spared for diabetes research by NIH in 2018. But what we see is 0.70% is dedicated specifically to diabetic foot ulcer research. So on a research ground, we see plenty of molecules, we see plenty of technologies coming up, and rightly mentioned by previous speaker, Mr. Arvinda, Dr. Arvinda, about the innovations about insulin deliveries, monitoring. But what is about the food side, which is one of the major cost to the healthcare systems, one of the major cost to that middle class family? That could be one of the major cause in the African countries where they are losing their earning capacity. Even to our undeveloped rural area, when the individual earning bread lost the leg, then what could be the financial status or the family status for those individuals? And building from there comes the research and prevention for uh, amputation is where we need to focus into. If I distribute this thing, then there is a patient-centric approach, which we as a diabetic RSSDI team, we always focus defeat diabetes. And that is one wonderful initiative by our president, that defeat diabetes is focused when the cause of diabetic foot is the diabetes, which should be defeated. That patient-centric approach, awareness approach, education approach is there. When it comes to the consultant level, yes, we are focused, overburdened, and we are skilled to manage to get those things into the glycemic range and train those individuals for prevention of amputations. But what are the other factors missing out? And still we are not reaching to the target. So healthcare provider level, what can be done? At the community level, what can be done? Yes, technology is one of the aspect. A clinical care, how we can generate the teamwork in our clinical practice, that is also one aspect. Healthcare insurance level, institute level, research level, what are the scopes? And to the healthcare governance levels, I'll just touch upon those things which can be put forward. And there are some of the put forwards which had been done by different innovators, entrepreneurs, or maybe the common man also. So I'll share on the our side what diabetic as a consultant we are doing. So primary prevention at the time of diagnosis, we can look for the good glycemic control, education of the food care, proper footwears, regular food care, repeated reinforcement about the food care, and modification and management of risk factors. If regular food examination by experts is also one of the key for the primary prevention of those individuals when they get detected with diagnosed with diabetes, and where they are regularly followed for ourselves. If we see the secondary, when they have the diabetic foot ulcer, then prevention of amputation, getting that ulcer to the worsening stage, that is also one of the aspects to look for. So good glycemic control, metabolic control, microbial control, wound control, vascular, these all are the team approach we are building up. But this is purely limited to the ulcers which are coming to our centers, our OPD practices, our clinical practice, or our hospitals, any setups. But what can be done further is not only the molecule levels. These molecules rightly mentioned for last 8 hours, and the faculties have provided the right dedication to represent these molecules to ourselves. But how about this Chinese saying? Yes, Chinese, we are losing out, but the saying is superior doctor prevent the disease, mediocre doctor treat the disease before evident, and inferior doctor treat the full-blown disease. So where we are landing, the whole system is building us around in a way that we should look to the inferior side, full-blown disease. Why we need to manage the foot ulcer at when it is there? Why can't we get to the superior level to prevent the that diabetic foot happen? And in that note, with help of these supports, yes, at the level of our advocacies as RSSDI, we are, or other associations, we are building up the governance level. We are advocating to the further level. But what can be possible at the community level? There are plenty of public awarenesses, there are plenty of social media campaigns, and rightly with our president's vision, the Facebook thing awareness is much more taken to the 10 times ahead level to the reach. the focus on feet, how we can reach to the feet focuses that can be built, and that had been built by default initiations, target populations, early prevention of preventive actions, develop of cost effective protocol treatments like what we developed, the RSSDI circle. That is one of the dedicated work had been done by our Dr. Urmandru and the with support of our president, that had been made to the Indian standards. But how we can make it to the same protocol level for our Indian diabetic foods as well as the international food, that is also one we can build up. And Project Shravan, which is one of our AIDR institutional work, and that had been supported. So community level awareness like food care, some of the representation of food cares, and this could be done to the further level that can be appreciated and awarded in the international level. That is where we look for. This is one of the recognitions of different country appreciating our feet washing ceremony to the further level, and that's where quoting the Project shown to the further level. So some of the community work, and to build up to the further level, what can be done to the innovations level, that should be focused on. So always innovation is not only to the technology side. The innovations can be communication side, community building side, the advocacy level side, or entrepreneur sides. And what we can build up to the healthcare is the must look for is quality, cost, safety, efficiency, and outcomes to deliver. And that to be focused on the patients or the friend with diabetic, that how the patients can be seen, how the patient can be heard, how the patient's need can be met. And to the technology side and the consultant side, to the focus to be treatment, diagnosis, prevention, education, research, and outreach of these facilities to them. And in that note, we are building the ecosystems around, and with all of your supports, it enrolls me to end up this session to match up the timeline with the invitation for next week meeting innovations by non-governmental organizations, where all dignified 27 countries are participating with 614 organizations till yesterday evening, and 240 cities of India are joining in, and where I can invite you for the session. So innovations where we can look for community work, we can look for, and with your and our associations collaborations and work forward, we can proceed further in to reach to the reality of diabetic foot amputation. Thank you once again to the RSSDI Gujarat chapter team, Dr. Pratap Jethwani, Dr. Shailesh Trivedi, and our president, Dr. Bansi Sabu sir, for inviting me to look for and aspire all of us for further reality to achieve this diabetic foot amputation prevention. To the over to chairpersons, please.
Thank you, Dr. Yash, for a very comprehensive outlook how to prevent amputations in diabetes. I'm running a foot care clinic since 2004, and the major pivotal event in the life history of a diabetic foot is development of ulcer. And if a foot transits through the stages of from healthy foot to the high-risk foot to the ulcerated foot to the infected foot, and then to the unsalvageable foot. But ulceration prevention is the primary thing, and secondary infection prevention is the primary thing. So if we really want to prevent amputations in diabetes, the most important thing, the awareness in the healthcare provider for the minor or a small ulcer under the foot is very important, and that will go a long way. Still, we are lacking even after so many years that there is no adequate awareness. Ulcers are treated and dressed for a long time by the surgeons or the general practitioners till it gets infected, and the infection spreads with severe cellulitis or and the stage of necrosis, and the unsalvageable stage comes forth. Thank you, Dr. Yash. Thank you very much.
Thank you, JL Sasha. So we'll keep it in discussion. That one of that indication is also, like you mentioned, you are managing the food clinic. The record keeping of those individuals is also one of the vital, because almost after 5 years of first diabetic foot ulcer, there are 80% of them gets the second ulcer or the mortality. And that is where one other pin is how to prevent the further amputation or the foot ulcer is also one of those aspects. Thank you for touching around. Yeah, I'll really appreciate.
Okay, thank you.
Now we have one video clip from the organizer. So I'll ask to play it.